Today, Dr. Karen Tawana will be presenting on managing food allergies with primary immune deficiency. This session is 45 minutes in length. We will be sticking to that time frame. If time permits, we'll be happy to take a handful of questions though at the end. A few things. Please also note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. And here at IDF, we offer a wide array of educational presentations, including presentations developed by healthcare and life management professionals invited to serve as presenters. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of IDF. But without further ado, I am proud to introduce our presenter, Dr. Tawana. Dr. Tawana is an associate professor at Baylor College of Medicine, Texas Children's Hospital, Department of Pediatrics, Section of Immunology, Allergy, and Retrovirology. She is a full-time clinician at Texas Children's Hospital since completing her Allergy and Immunology Fellowship at the same institution. She is a clinical immunologist and has published several papers on immunology and food allergies, which is her main interest. Welcome and thank you for joining us, Dr. Tawana.
Thank you, Julia. Good morning, everyone. I'm really honored to be here today and given the opportunity to share something I'm really passionate about, which is food allergy. So, our objectives for today are to understand the prevalence of dietary allergies in the PI community, to learn tactics to maintain proper health and nutrition despite dietary restrictions, and to be able to outline the important steps to take to prepare for an allergic emergency. So why is it important for us to know food allergies in PI or allergies in general? As patients having a primary immune deficiency, you're already dealing with infections and managing it. But a lot of people outside the PI community, even in the medical field, are not aware that PI can also be associated with other chronic conditions like allergy and autoimmunity. In fact, it is very important because it can be the initial presentation of PI, especially in children. Furthermore, failure of recognition of PI conditions that can masquerade as allergic disease may interfere with the early diagnosis and treatment and can have a significant bearing on the outcome. As you can see here, both of these children presented with severe eczema or atopic dermatitis in infancy. Both have normal newborn screen for SCID. The child on the left had also recurrent viral infections, chronic diarrhea, and multiple food allergies, while the child on the right had 3 episodes of severe skin infection with staph. Oh, it's hard. Sorry. Thank you. Again, the child on the right had 3 episodes of severe skin infections caused by staph and herpes simplex, and also had a bone infection caused by staph. So if children with early onset severe eczema or atopic dermatitis get serious infections, that's already a red flag that one should investigate for a PID. So actually the child on the left has IPEX, or your immune dysregulatory polyendocrinopathy and enteropathy X6 syndrome, and the child on your right has hyper IgE syndrome. However, the data on prevalence of allergic conditions in PI, as well as how allergies are diagnosed in PI, is limited. Of course, we have all of these databases, but majority are self-report. This is the data from the USID-Net in 2015, where I did compare the prevalence of food allergy and atopic dermatitis in PI community and the general population. And as you can see, the prevalence of food allergy and atopic dermatitis is lower than the general population. More recently, this is a slide showing global data from USID-Net and World Allergy Organization. These responses were received from 30 centers in 23 countries spanning 6 continents. The top yellow graph represents the results from the World Allergy Organization, while the orange bar graph down represents data from the USID-Net. And as you can see, the prevalence of food allergy is only 1.3%. and is much lower based on the USID net data, which is 0.1%. But interestingly, the prevalence of anaphylaxis is lower from the World Allergy Organization at 0.3%. And the most common trigger would include your antibiotics being the top one, IVIG, the second top trigger, and the third top trigger is food. The USID net, however, had a higher incidence of anaphylaxis at 10.8%. And here, the data, the top triggers for anaphylaxis include drugs, which is the top one, and food actually is the second top trigger. Now, about 8% of patients with PI presented with allergic disorders, and there was a delay in the diagnosis of their PI caused by an initial presentation of allergic disease in about 7.5%. So this is quite high. Hence, it's really important for us to be aware that PI can present with allergic disease to prevent or avoid delay in the diagnosis of PI. This shows you the distribution of the different groups from the data from the World Allergy Organization. So majority of the responses were from patients with predominantly antibody deficiency, followed by combined immunodeficiencies, then congenital defects of your phagocytes like CGD, and then immune dysregulatory disorders. Now, what are the PI conditions that present or have concomitant allergic disease? So primary or predominantly antibody deficiency ranked the most common PI with allergic disease in both databases, the World Allergy Organization and USID net. And among those with predominantly antibody deficiency, almost half of them had selective IgA deficiency. For the combined immune deficiencies, 43% had hyper IgE syndrome and 38% had viscous allergy syndrome. And then the third most common PI that have allergic disease are your diseases of immune dysregulation. And then lastly, your congenital defects of phagocytes. Asthma was the main allergic disease in predominantly antibody deficiency, while it was atopic dermatitis or eczema in combined immune deficiency. Food allergy was still present in all of the categories of PI, the predominantly antibody deficiency, combined immune deficiencies, and diseases of immune dysregulation. And most of the diagnosis was made by specific blood testing of allergy antibody to the food allergens, skin prick tests with food allergens, or directly a oral food challenge. So these are, again, to summarize, well-known PI conditions associated specifically with food allergy. You have your hyper IgE, your IPEX, your viscous allergy syndrome, selective IgA deficiency, and common variable immune deficiency. And the one thing common about these PI conditions is there is an absence of a fully functional immune system that results in breakage of your tolerance, resulting in allergy and some autoimmunity as well. And these conditions have chronic allergic diseases and are on chronic allergy treatment. In general, food allergy has been increasing in the general population. In the US, about 7.6% of children have food allergies, while it is present in 10.8% in adults. Why is it increasing? It's still up in the air. We don't know exactly why. One study has found that food allergies significantly increase in children who are born in urban areas compared to children born in rural areas, suggesting that urbanization is leading these increases in food allergy. Again, as I said, we still don't know the exact cause of food allergy, as it is a complex immune disorder caused by specific genetic variants influenced by a combination of your environmental and nutritional exposures. I just want to share you one popular hypothesis now that's been up and coming to explain this increase in food allergy. It's known as your epithelial barrier hypothesis, or your lining of the skin and gut barrier defect. When there's a defect in your barrier, bacteria will colonize it, resulting in the change of our normal bacterial flora in the skin and in the gut. This is what they call microbial dysbiosis. And this microbial dysbiosis leads to inflammation in the gut and in the skin. However, not all patients will develop food allergies, as again, you still need that genetic predisposition, as well as triggers that will promote this breakdown of the barrier. Again, there's a lot of potential triggers that will contribute to this barrier defect. Aside from your allergens, you have infectious agents, and more recently, even reports of laundry and dishwasher detergents, household cleaners, emulsifiers in food, pollutants like smoke, diesel, ozone, and microplastics. Let's switch gears for a bit. So there is a lot of misuse of the word allergy. One has to remember that allergy is not the same as intolerance, and I think it is very important to distinguish these two, as incorrect identification can lead to inappropriate diets with nutritional deficiencies. And you have to remember that having nutritional deficiencies alone can also produce immune dysfunction. So we really have to be careful in patients with PI. Now, when we use the term food allergy, it is immune-mediated, and it is an adverse effect arising from a specific immune response that occur reproducibly on exposure to given food, while food intolerance is not immune-mediated. Moreover, food allergy can be life-threatening, while food intolerance is not. The top foods may also differ from food allergy and intolerance. So you have your top 8 food allergens, which are your dairy or cow's milk, egg, peanuts, shellfish, soy, wheat, tree nuts, and fish. And now more recently, FDA included sesame in the top 9 food allergens. While for food intolerance, again, you also have your dairy products or milk, gluten products, additives, foods containing biogenic amines, or gas-forming foods like cabbage and beans. Now, the symptom for food allergy mostly commonly involves the skin, like hives or swelling, but can also involve your breathing, your respiratory, cardiovascular, gastrointestinal, and even your nervous system. While for food intolerance, it's mostly a GI or a gut, but can also have throat closing, coughing, and even headache, irritability, and nervousness. This is just a table to compare the two. Again, symptoms for food allergy is quick. It happens within minutes after eating that food, to as long as up to an hour. While for food intolerance, the symptoms appear hours after eating that food. Again, for the cause, the food allergy, it's due to the food proteins. While for food intolerance, there are many variable causes like lack of digestive enzymes and foods that irritate the gut. And again, the immune system is not involved. Diagnosis for food allergy can be done several ways. A blood testing measuring that allergy antibody to the specific food, or doing a skin prick test to the food allergen, or even doing an oral food challenge in clinic. While for food intolerance, we usually tell patients to note down, get a food diary, and note the common foods that that triggers their symptom, doing an elimination diet, or even a reintroduction or food challenge. Since food allergy is life-threatening, treatment is obviously strict avoidance of the food trigger. And sometimes unavoidable accidental exposures can happen, and we do treat them with antihistamines like your Benadryl and the life-saving device epinephrine. While for food intolerance, you can still eat that food, but you have a certain threshold as to how much you can tolerate it. Now, for food allergy, this is what we give mostly to our patients, especially children. It's a food allergy action plan. It includes the allergens or the triggers, the symptoms, what symptoms to look for, the medications to use, the doses of the medications, and where the medications are kept. And it's divided into two, depending on the severity. For mild symptoms, meaning just only involving the skin, you can treat it with your antihistamines like Benadryl or Zyrtec. It acts quickly within 10 minutes. While for severe, It's more than the skin. That's the easiest way to remember. If it's more than the skin, you need your epinephrine and then your Benadryl. Some patients who have concomitant asthma may also need their rescue inhaler albuterol. These are examples of your epinephrine devices commercially. Again, they have the same mechanism for the device, where there is a cap that you have to pull out, and then the other, then you inject on the upper outer thigh where there's a thick muscle, and then you hold it for 2 to 5 seconds, and then call 911 or go to your nearest emergency, and then you still need to give your Benadryl or your antihistamine. Now switching gears, for food intolerance or non-allergic food sensitivities, it can be divided into host-dependent and host-independent. Now for host-dependent, meaning your body doesn't have produce much enzymes or there's a metabolic issue. While for host-independent, it's the food itself that causes that irritation in your gut. Again, this is just a summary. You're dividing your different types of food intolerances. Now, celiac disease is the only exception to the rule for food intolerance, because this is the only food intolerance that is immune-mediated. And then you have for your undefined, now becoming more popular, your FODMAP or your carbohydrate malabsorptions, and your non-celiac gluten sensitivity, which we still don't know exactly what the cause. So for food intolerance, you have your 3 major food groups here that are implicated for causing the symptoms. You have your dairy, that can also, you have your lactose there. You have your wheat products that contain gluten, but remember rye and barley can also have gluten. And then your fermentable carbohydrates or your FODMAP. So let's go first with milk or your lactose intolerance. There are 3 different kinds. The first one is your lactase deficiency. Now, some were born with with congenital absence of lactase enzyme, and it's quite rare. But mostly what we see is a decreased activity of the lactase enzyme over time, and mostly found in older children and adults. Lactose malabsorption, this is what we encounter a lot and what patients have, and it's from an incomplete absorption of your lactose. It is highest among Asians and lowest in Scandinavian population, and in fact the global prevalence of this one is 68%, which is quite high. And your typical symptoms would include abdominal pain, nausea, vomiting, bloating, diarrhea, and increase in flatulence. And it occurs, as I mentioned, few hours after your lactose ingestion. There is a test that can be done, which is your hydrogen breath test. It's like a pregnancy glucose tolerance test where they give you a certain amount of carbohydrate and then measure your breath and measure the gases there. And last one, we have the lactose sensitivity, which has the same symptoms as your lactose malabsorption, but have other extra-intestinal symptoms like headache, brain fog, musculoskeletal pain. And most patients with irritable bowel syndrome or IBS have lactose sensitivity. So what do we do, as I mentioned? Of course, you have to avoid lactose using lactose-free products or other non-dairy alternatives. Now, there's a lot of alternatives you can find in your regular grocery stores. You don't have to go to special grocery stores anymore. However, one must remember that you make sure that you have to supplement with calcium and vitamin D. But I do believe even now the non-dairy alternative products are fortified with calcium and vitamin D. For younger children, just to make note, your almond milk or your cashew milk have less calories compared to your oat milk and your soy milk. Another way of treating your lactose intolerance is taking the lactase enzyme. However, this is short-lived, and you have to take that enzyme pill 5 to 30 minutes before consuming lactose-containing foods. Now we have gluten sensitivity. And as I said, celiac disease is the only one that involves the immune system. It is a chronic condition that results in small intestinal injury due to gluten ingestion. Again, even if it's immune mediated, it's still not an allergy. It affects 1.4% of the population, and there are markers in the blood that can be detected to aid in a diagnosis of celiac. Presenting symptoms are different depending on your age group. Like infants and children present with decreased appetite, abdominal distension, diarrhea, vomiting, and growth delay, or even short stature. While older children and adults may present with diarrhea, bloating, constipation, abdominal pain, and even weight loss. Adults can also have headache, fatigue, and neuropathy. Now, non-celiac gluten sensitivity has similar symptoms like your celiac, but they don't have the markers diagnostic for celiac disease. And it's mostly found in diagnosed in the third and fourth decade of life, mostly in females, and it results from incomplete digestion of your gluten proteins. Or some say that gluten changes the gut motility and gut absorption. Currently, there's no diagnostic criteria for non-celiac gluten sensitivity, hence it's a diagnosis of exclusion. So you have to make sure you don't have celiac disease first. And usually requires elimination of your gluten. Then you have IBS. Again, this is the most common functional gastrointestinal disorder. It is multifactorial, influenced by stress, genetics, infection, and again, your microbial dysbiosis. There are 3 different types. One can present with constipation, another one with diarrhea, or some groups will have diarrhea and constipation. And one of the other, aside from gluten, another common trigger for IBS is your carbohydrates, your fermentable carbohydrates. Again, just to summarize, these are your food intolerance that are host dependent. You have your celiac disease and non-celiac gluten sensitivity and your irritable bowel syndrome. So what do we do for gluten intolerance? Once you have a gluten-free diet, you have to remember that your diet will be less in fiber, vitamin D, vitamin B12, and folate. And of course, there will be less of your minerals like iron, zinc, magnesium, and calcium. Having a gluten-free diet, because of the alternatives, will be having higher fat content. It's very restrictive, and obviously it's more expensive if you look at if you compare it with your regular gluten products. Now we go to carbohydrate malabsorption. Again, they have similar symptoms like your celiac and lactose intolerance. You have abdominal bloating, increased flatus or flatulence, abdominal distension, and diarrhea. And again, this is from your ingestion of complex carbohydrates, fibers, and starches. Or they say it's due to excessive ingestion of your FODMAP. It's a mouthful. It's fermentable oligosaccharides, disaccharides, monosaccharides, and polyphenols. So it's better known as FODMAP. Now, here's a table, and I divided into food groups, which foods have high FODMAP and have low FODMAP. Don't worry, I will share the slides with you with IDF, because I know this is a very interesting table. Because I am also surprised with some of the vegetables that are high in FODMAP. So here you have your vegetables, your fruits, your dairy, and other alternatives, breads, cereals, nuts, and seeds. Even nuts, I would think, will have a high FODMAP. Having a low FODMAP diet, again, you are restricted with wheat, dairy, some vegetables and fruits, and of course you'll have less fiber, calcium, iron, zinc, folate, vitamin B and D, and of course your natural oxidants. Now, an interesting type of food intolerance is host-independent ones, wherein the food itself is irritating to your gut. And we do have natural substances that occur in foods. Histamine is the top one here, histamine intolerance, where there is accumulation of histamine either to decrease degradation of the enzyme or ingestion of large quantities of the histamine food. And I'll have a table again showing what are the foods that are high in histamine. This affects 1% of the population worldwide and 80% are adults. Now, salicylates can also present like an allergic reaction. You can have hives, swelling or angioedema, wheezing, rhinorrhea or rhinitis, nasal congestion, and even an IBS trigger. And of course, you have your chili peppers or capsaicin can be an IBS trigger as well. Then for your nitrates, your additives like your nitrates and which are used as preservatives for a lot of deli meats. So you can cause wheezing, headache, migraine, and we all know what aspartame is. Anything that has sugar-free has aspartame. So it can cause headache, migraines, brain fog, low mood, depression, and even anxiety. Again, these are some of your other natural and additive things found in food. MSG, similar to an allergic reaction, you can have wheezing, rhinitis, but can also have neurological symptoms like headache, migraine, and brain fog. Caffeine can be an IBS trigger, can cause dyspepsia, headache. Sulfites, again, like hives, wheezing, and then benzoates can cause eczema or even dermatitis. So again, these are the foods where you can find your naturally occurring additives and preservatives. For MSG, salicylates. See, I was surprised about this one. Unpeeled fruits and vegetables can have high salicylates, like your apples, your strawberries. And then your sulfites, and then your benzoates. And then here are the other additives or food examples where you can find these additives and naturally occurring substances. See, for histamine, cheese is a popular one. Anything fermented will have high histamine content. Fish, even pork. And then for thiamine, again, it's also cheese. And nickel can be found in your oatmeal. Nickel can cause eczema as well. And then other minor food-related diseases. You know, I see this a lot in clinic where parents come. I think my son or my daughter is allergic to milk because I noticed increase in mucus in their nose and in secretions in their mouth. But unfortunately, several studies have not shown that cow's milk increases mucus production. So we need a lot more data on this one. And a more popular one is acne, a diet high in saturated fats, dairy, and chocolate can give you acne. Again, no controlled clinical trials that confirm a link between the diet and acne. And I think that's, yeah. Thank you for listening.
All right.
Yeah, it's okay. It's an additional information.
Fine. All right. Thank you so much,
slide.
Dr.
Yeah.
Tuano.
Don't worry about that.
This is great. I was going to say that's actually amazing now. All right. Well, now I'm just going to quickly share a couple of IDF resources here, and then we do have a little bit of time for Q&A. So if you leave here today with a lingering or unanswered question, please submit it to our Ask IDF platform, and a member of our team will reach out to you directly to provide support or connect you with the appropriate resource. Likewise, we can also help you get connected with others in the PI community through our virtual Get Connected groups. IDF Get Connected groups offer individuals with PI and their family members the opportunity to connect, share experiences, and receive support in their local communities. Finally, please remember to complete the session survey through the conference app for the session. And again, now we do have some time available for Q&A. I'm actually going to bring the mic around to you, so just please raise your hand and just try to keep all the questions related to this topic. So, right there. Thank you. Yep.
Thank you for an informative presentation. I have a quick question. I was diagnosed with a shellfish true allergy in the last couple of years, and I don't test positive on blood or skin tests for the shellfish allergy. It was all on symptoms alone. Is that pretty prevalent in the PI population not to test positive on those skin and blood tests?
Yes, actually for those with hypogammaglobulinemia, or specifically XLA, yeah, so they don't, you don't produce IgE, right? Because you don't produce your immunoglobulins. So for the immunoglobulins, it starts with IgM, right? But there is a problem when you have XLA. And so your IgM will stay there and not switch to IgE, IgG, or IgA. So that's why we cannot measure any IgE for those patients with XLA.
Well, not XLA.
Okay. Oh, CVID, yes.
Just because I don't have enough IgE, but I can still have a reaction.
So it will be nice, like for you personally, how many times did that happen?
Twice anaphylaxis.
Twice anaphylaxis. Yeah. So there is a common differential diagnosis, particularly for shellfish allergy. And for those who just have one-time reaction, we call it scromboid toxin. That toxin, you get it from, not fresh or sick seafood. And that scromboid is a chemical that's very similar to histamine, which is your allergy chemical. And so you can have allergic symptoms that mimic an allergic reaction. But when you try it again after having a negative skin test or a negative blood test, you may be able to tolerate the food. But again, for PI, it's very, very different because you may not produce enough IgE to be present in the blood or in the skin prick test.
Okay. I'm going to hold the mic here for you guys just a minute.
Hi there. My question is, how often should somebody with PI get allergy or food allergy tested? Like, do things change within, say, 5 years?
Yes, so if you have symptoms, we recommend it. Like for children, we do them every year to see if they outgrow it. And then we stop at a certain point when we think they're not going to outgrow it anymore. So for adults, it's different because there are food allergies that are adult in onset. It's mostly your nuts and your seafood. And so again, we don't have a lot of data, so we do recommend retesting every 2 years at least, yeah.
Come up here. We've got time, folks, so hang on.
Sorry. So my question is, my sister has CVID, and she has a lot of severe reactions. We have been unable to differentiate if it's medicine related or if it's stomach related.
Yeah.
How do you know which way to go?
Yeah, it's quite tough if you cannot figure it out. So again, the diary is not exclusive for food. If you think it's a medication, it will be nice to note it and then see what's the common denominator in your food diary. For foods, we can also do a challenge, supervised, of course, by a clinician in the clinic.